Hi there, Vic Veer, ENT surgeon. And in this video, I want to tell you about why I think poor sleep is really difficult to treat in today's sort of modern medicine. I think the main problem is that partly because of doctors, we've all started splitting off into our own little specialties because medicine's becoming harder and harder to do. And you can't, there are very few sort of generalists left anymore. So becoming a sleep doctor doesn't really exist because there's lots of people that help people with sleep problems. And so all of our little specialties are all dividing up. And that becomes a problem. So, for example, let's take a 55, 56-year-old lady who's just gone through the menopause. Because of the drop in estrogen, she's got a little bit of rhinitis or a blocked nose. You can gain a little bit of weight as well. And your thyroid levels can change slightly during this period. So that also impacts on weight gain as well. On top of that, they have a loss of collagen and elasticity in their body, and therefore people start snoring and having problems with obstructive sleep apnea, which is when you snore so badly, as it were, that the airway sort of partly blocking, getting a little bit of air through. You start having sleep apnea where you stop breathing, go a little bit blue, wake up a bit, and then go back to sleep again. Now, actually, at that point, it's not too difficult to deal with. It's quite easy actually to deal with someone with that problem. You just help out with the menopause, help out with the elasticity and other problems in the throat, and it's easy to fix. But the problem is, NHS waiting lists are quite long now. By the time you get someone to believe you that you have a problem, get a sleep study, and get seeing the right person, things have moved on a little bit. Because of the sleep apnea, these people have become a little bit more tired. They're more embarrassed about going out to, say, spa dates with their girlfriends, and they're like, "Oh, I don't want to upset everyone in the room. I'll have to get a separate room, and it's a bit embarrassing. No one wants to share with me. I can't go out on holiday with my friends." And so you become slightly socially isolated, you get a bit frustrated, you get tired, and often people start thinking, "Well, it's really embarrassing. I don't really want to sleep until my partner's gone to sleep." So you wait for the partner to go to sleep, and you're not getting much sleep yourself, and you end up sort of being fearful of sleep. And that's almost the start of one of the reasons why a lot of people get insomnia with obstructive sleep apnea. So on top of their obstructive sleep apnea, they've got insomnia, they're even getting even less sleep, even more sleep deprived. That causes more weight gain because we've talked about this quite a lot. It's not that you gain weight and then you get obstructive sleep apnea. It's often the other way around. The sleep apnea causes you to gain weight, and it's very hard to lose the weight once you have obstructive sleep apnea. There's another video about that. If you, I'll put it up here for you. So when initially you had a little bit of a problem with the menopause affecting your airway, you now have got menopause or perimenopausal problems. You've got snoring, obstructive sleep apnea. You've got a sense of frustration, insomnia, depression, stress because of this issue, thyroid problems, weight gain. All of these things are now starting to build up, and it becomes increasingly difficult to help these people purely because they've had to wait so long to see us on the NHS. And then when you see these patients, it becomes really difficult to unpick all of this to work out what you should treat. And as a surgeon, what do I know about menopause? I know nothing. And I need to get other people involved, and everything sort of spirals out of control. And it doesn't just happen to perimenopausal women, it happens to young people as well. Young men have this problem all the time. So in younger people, a lot of people don't realize that tonsils generally disappear by the time they become adults. They start disappearing at puberty. And therefore, you think, well, actually, why does this adult have big tonsils? And those big tonsils can cause problems purely because they're in your mouth like large meatballs. And every time you breathe, and when you get a little bit into deep sleep, they and stop your breathing altogether. Now, as a child, you just take your tonsils and adenoids out, and in most cases, that solves the problem. But when you're an adult with big tonsils, you've got responsibilities with work, you've got a young family to deal with, you're not getting much sleep because of this young family, and you're trying to negotiate being productive, doing well at your job, going up the career ladder, whilst not having very good sleep. And that can, again, cause insomnia, depression, stress, and things like that. Because of this, they become less productive, they're more likely to lose their job, go into poverty and things like that. So it's really difficult for these people because it robs them of problems that they could have easily dealt with when they were perhaps younger if they'd seen the right person. So by the time they see us on the NHS, they're in a really bad state. They don't have a job, they're depressed, gained weight. They may also have other problems like restless leg syndrome. They may have got into a car accident and they've lost their driver's license. Their whole world is coming down. It's very hard to help them sort of pull themselves out of that downward spiral. I think this is all to do with the fact that we have a really long waiting list and too many people and too few doctors around to look after these people. And then you throw in economics and poverty and politics into the situation where in London at the Royal National ENT Hospital where I work, I've got bariatric care, I've got a sleep neurologist, I've got dental team. We're putting in implants, these really expensive bits of kit into people's chests so they can get rid of their obstructive sleep apnea. All of this stuff is going on. But in some parts of the country, say rural Wales or some other places where they don't really have much access to sleep centres, then it's really difficult for those people. It doesn't mean that Londoners need more. It's just that's where the stuff is, and that's politics, and that's economics for you. So often in different centres around the country, they may only have a respiratory centre that can only provide you with a CPAP device, which is great for some people, but not perfect for everyone. And if they don't have enough staff to look after you afterwards, get to see a doctor, change the settings, help you out with any difficulties you're having with the CPAP, you're sort of left alone with that because there's just not enough doctors around there to look after these people. And then if you don't get to have CPAP, you're left untreated with obstructive sleep apnea. You can have high blood pressure, diabetes, all these things, depression as well. There's this interesting thing about depression and heart failure where there's a cyclical relationship. So depression causes obstructive sleep apnea causes depression. So again, another downward spiral. The same thing with heart failure as well. So all these things are really important. A lot of people get picked up with obstructive sleep apnea purely because they get atrial fibrillation, a sort of fluttering of the heart, and they get their shock treatment or whatever it is, and it doesn't seem to work. And then the cardiologist thinks, "I wonder if you've got sleep apnea or something like that." Often they don't think of it because most people, well, not most people, but a lot of people with obstructive sleep apnea aren't enormously fat, which is what everyone thinks. Oh, sleep apnea is because of the fact that you're very big. A lot of people with obstructive sleep apnea are not large at all. They're just normal size. The average BMI in this country is 28. And I found in our study that the average BMI of sleep apnea patients is 29. There's not much difference between the two. So what I'm saying is that I think generally me and lots of doctors around the country are failing these patients. We're not getting to see them quickly enough. And if we do get to see them, the waiting list is so long to get treatment, investigations and stuff, that we struggle to get them out of this downward spiral before it becomes really difficult to pull them back out. And I have, I've been doing this YouTube channel hoping to spread some knowledge and education out there, but a YouTube channel and some videos about mouth taping and, exercises if you throw it, that only helps some people. And actually people need proper care. And what tends to happen is that people see me or a respiratory physician, they try one treatment and go, oh, that didn't work. Let's try something else. You sort of pass around from clinic to clinic, not really getting the treatment you need. And so my plan, which is, I guess, a little far-fetched, but what my hope is that I want to make a new Sleep MDT. MDT stands for multidisciplinary team, and what that means is I want instead of patient coming to see me and then going, "Oh, I think you've got this, this, and this. Go and see those people as well, and I'll carry on with my thing." I think when patients come to a sleep center, they should just see all of us. They should see a dentist, or orthodontist, or maxillofacial surgeon, a respiratory physician, a sleep neurologist, an ENT surgeon, check their nose, check the tonsils, and all sorts of people, myofunctional therapists, all the sorts of people come together to see this patient, make their assessment. And then what I'm hoping for is that that person gets a list of things that we think as a team, because we all get together and discuss that patient and say, look, this person's got restless leg syndrome. This person's overweight, so we got to get the bariatric team to see him as well. This person's got insomnia. He's got obstructive sleep apnea. We need to do these 8 different things. So let's give that proposal to the patient and see if they'll go for it. And then they can go ahead with all of these treatments at the same time. Because I think personally, speed is of the essence in this situation. Trying to get them before they descend too low into this little pit, as it were, trying to sort out all these problems at once. It means, unfortunately, lots of different consultations, but at least they're running in parallel rather than going from me to the next clinic, to the next clinic, to the next clinic, and it's spending years and years to get through it. If you're seeing everyone at the starting gate, and then you're seeing all of us over a period of, say, I don't know, a year or something, then hopefully we can get through all of this. It means a lot of consultations, but I think sleep is complex and it's important. We spend more than a third of our lives sleeping, and if you're not getting good sleep, you only then do you realize how important it is. Young parents, when they first have their babies, they had no idea how awful life is if you don't get enough sleep. You get really ratty and everything becomes awful. But anyway, but this is not just sleep deprivation, it's all the side effects of having obstructive sleep apnea, the psychological impact, the impact on your heart and lungs. Talking about heart and lungs, I think you need a cardiologist to see these patients, endocrinologist with an interest in menopause. All sorts of people need to be involved in the sleep center. Um, yeah, that's my plan. A sleep MDT. I'm gonna try and put this thing together, and I hope people out there will support me, like hospital managers and politicians and stuff like that. But, I will I'm gonna try and start a blog and a podcast because these videos are difficult for me to do. I haven't got enough time for all of this. But, I can get more information out there. Hopefully, I can give you some information that you can sort of understand what you're looking for and who you need to see if you can't get to see me and my sleep sort of MDT thing on the NHS. But if you want to recreate that, you can say, well, actually, dear GP, I think I need to see these four people because I've worked out that I need to do this, 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 and this. And then instead of you going from place to place in a linear fashion, you're seeing everyone in parallel, and you get sorted out quicker. I hope that's going to work. I really do hope it's going to work. And I think also it'll be a better outcome for people. I think the me doing an operation on someone is useful, but you also need to help them with exercise, weight loss. You need to help them with the insomnia as well. People may have a fantastic AHI. Oh, you brought my AHI down from 40 down to less than 5, but I still feel rubbish. And you think, oh God, what am I going to do now? And you think, oh, actually, yeah, you've got a bit of restless legs, you've got insomnia, you've got all sorts of other things. And I feel like I'm not doing the best thing for my patients because I can't be everything. And I feel a bit rubbish about it. Um, is no value in this video. I'm so sorry. I just wanted to have a little rant about it. Do take care. Bye bye.